In this session, we will discuss the impact of electronic health records on nursing workflow. At the end of this session, you will be able to assess the benefits of implementing an electronic health record and evaluate the flexibility of the electronic health record in meeting the needs of the clinicians and patients. The significance of electronic health records, or EHRs, to nursing cannot be underestimated. Although EHRs on the surface suggest a simple automation of clinical documentation, in fact their implications are broad-ranging from the ways in which care is delivered to the types of interactions nurses have with patients in conjunction with the use of technology, to the research surrounding EHRs that will inform nursing practice for tomorrow. A basic knowledge of EHRs and nursing informatics is now considered by many to be an entry-level nurse competency. In 2004, President Bush raised the profile of electronic health records in his State of the Union address by outlining a plan to ensure that most Americans would have an electronic health record by 2014. This goal was reaffirmed by President Obama. The American Recovery and Reinvestment Act of 2009, or ARA, including the HITECH Act to specifically incentivize health organizations to become meaningful users of EHRs. These incentives will come in the form of increased reimbursement rates from the Centers of Medicare and Medicaid Services. Ultimately, the HITECH Act will result in payment of a penalty by any healthcare organization that has not adopted EHRs by January of 2015. Criteria for certification of electronic health records has been developed by the National Institute of Standards and Technology and endorsed by the Office of the National Coordinator for Health Information Technology for EHRs. There are 45 certification criteria ranging from basic ability to record patient demographics, document vital signs, and maintain an up-to-date problem list to more complex functions such as electronic exchange of clinical information and patient summary records. With the exception of EHR infrastructure functions such as security and privacy management, controlled medical vocabularies, and interoperability standards, the 45 criteria or standards map into the Institute of Medicine categories. The final rule was published by the Department of Health and Human Services in July 2010 for the first phase of implementation. Stage 1, meaningful use criteria, focus on data capture and sharing. Stage 2 criteria, which are slated for implementation by 2014, advance several clinical processes and promote health information exchange, or HIE, and more patient control over personal data. Stage 3, which has a target implementation date of 2016, focuses on improved outcomes for individuals and populations and introduction of patient self-management tools. Higher stages of electronic medical record adoption models include more sophisticated use of decision support tools and medication administration tools through Stage 7, where the electronic medical record has data sharing and warehousing capabilities and complete interface with emergency and outpatient facilities. If optimization efforts are undertaken, the need to revisit workflow design should not be considered a flaw in the implementation approach. Even a well-designed future state workflow during a technology implementation must be re-examined after implementation to ensure that what was projected about the future state remains valid and to incorporate any additional workflow elements into the design process. Electronic health record is defined as a data warehouse or repository of information regarding the health status of a client, replacing the former paper-based medical record. It is the systematic documentation of a client's health status in healthcare in a secure digital format, meaning that it can be processed, stored, transmitted, and accessed by authorized interdisciplinary professionals for the purpose of supporting efficient, high-quality healthcare across the client's healthcare continuum. The Institute of Medicine definition also remains a valid reference point. This definition is useful because it has distilled all the possible features of an electronic health record into 8 essential components, with an emphasis on functions that promote patient safety. a universal denominator that everyone in healthcare can accept. The 8 components are health information and data, results management, order entry, decision support, electronic communication and connectivity, patient support, administrative processes, and reporting and population health management. Let us look at each of these in more detail. Health information and data is the patient data required to make sound clinical decisions, including demographics, medical and nursing diagnoses, medication lists, allergies, and test results. Results management is the ability to manage results of all types electronically, including laboratory and radiology procedure reports, both current and historical. Order entry management is the ability for a clinician to enter medication and other care orders directly into a computer, including laboratory, microbiology, pathology, radiology, nursing, supply orders, ancillary services, and consults. Decision support is the computer reminders and alerts to improve the diagnosis and care of a patient. Electronic communication and connectivity is the online communication among healthcare team members, their care partners, and patients, including email, web messaging, and integrated health record within and across patient settings, institutions, and telemedicine. Patient support is the patient education and self-monitoring tools, including interactive computer-based patient education, home telemonitoring, and telehealth systems. Administrative processes are the electronic scheduling, billing, and claims management systems, including electronic scheduling for inpatient and outpatient visits and procedures, electronic insurance eligibility validation, claim authorization and prior approval, identification of possible research study participants, and drug support recall. Reporting and population health management is the data collection tools to support public and private reporting requirements, including data represented in a standardized terminology and a machine-readable format. The HIMSS-Davy Award may be the best resource for combined quantitative and qualitative results of successful EHR implementation. The Davies Award recognizes healthcare organizations that have achieved both excellence in implementation and value from health information technology. One winner demonstrated a significant avoidance of medication errors because of barcoding scanning alerts, a $3 million decrease in medical record expenses as a result of going paperless, and a 5% reduction of duplicate laboratory orders by using computerized provider order entry alerting. Another winner noticed a 13% decrease in adverse drug reactions through the use of computerized physician order entry. It also achieved a decrease in methicillin-resistant Staphylococcus aureus, or MRSA, nosocomial infections from 9.8 to 10,000 discharges per 10,000 discharges to 6.4 per 10,000 discharges in less than a year using an EHR flagging function, which made clinicians immediately aware that the contact precautions were required for the MRSA-positive patient. At both organizations, there was a qualitative and quantitative evidence of high rates of end-user adoption and satisfaction with the use of the EHR. A 2011 study of the effects of EHR adoption on nurses' perceptions of quality care, communication, and patient safety documented that nurses report better care outcomes and fewer concerns with care coordination and patient safety in hospitals with a basic EHR. In this study, nurses were perceived that in hospitals with a functioning EHR, there was better communication among staff, especially during patient transfer, and fewer medication errors. Without an EHR system, any of these benefits would be very difficult and costly to accomplish. Thus, despite limited standards and published studies, there is enough evidence to warrant pursuing widespread implementation of the EHR, and certainly enough evidence to warrant further study of the use and benefits of the EHR. The process of becoming a successful owner of EHR has multiple steps. It requires integrating the EHR into both the organization's day-to-day operations and the long-term vision in the clinician's day-to-day practice. The first step of ownership is typically a vendor selection process. EHR certification ensures that a quality product will be selected. Select a system based on your organization's current and predicted needs. The criteria should include both subjective and objective items that cover common topics such as clinical workflows, decision support, reporting, usability, technical build, and maintenance of the system. Implementation planning should occur concurrently with the selection process, particularly the assessment of the scope of the work, initial sequencing of the EHR components to be implemented, and resources required. The implementation plan should also account for the long-term optimization of the EHR. Financial and patient privacy hurdles must also be overcome to achieve an expansive EHR. The Department of Health and Human Services recently loosened regulations so that physicians may now be able to receive healthcare IT software, hardware, and implementation services from hospitals in an effort to alleviate the cost burden on individual providers and foster adoption of the EHR. Patient privacy is a pivotal issue to determining how far and how easy it will be to share data across healthcare organizations. For health information, exchanges to reach their full potential to the public must be able to trust that their privacy will be protected, or else risk that patients may not share a full medical history, or worse yet, may not seek care, effectively making the exchange useless. End-user adoption of the EHR is also essential to realizing its benefits. Clinicians must be engaged to the use of the EHR successfully in their practice and daily workflows so that data may be captured to drive the decision support that underlies so many of the advantages and metrics described. To promote adoption, a change management plan must be developed in conjunction with the EHR implementation plan. The most effective change management plans offers end users several exposures to the system and relevant workflows in advance of its use and continue through the go-live and post-live time periods. Successful pre-live strategies include end-user involvement as subject matter experts to validate the EHR workflow design and content build, hosting end-user usability testing sessions, shadowing end users in their current daily work in parallel with the new system, and formal training activities. Despite the challenges, the future of EHRs is an exciting one for clinicians alike. Benefits may be realized by standalone EHRs as described here, but the most significant transformation will come as interoperability between the systems. There is a wealth of descriptive data available pointing to the benefits of an EHR. Nurses must stay engaged in this evolution and help shape its direction, as it has already proven to have a significant impact on our practice and our patients. The future also holds tremendous potential for EHR features and functions that will include not only more sophisticated decision support and clinical reporting capacity, but also improved biomedical device integration, ease of use and intuitiveness, and access through more hardware platforms. Implementations of EHRs will become more commonplace in the near future with the American Reinvestment and Recovery Act putting pressure on healthcare organizations to move more quickly toward adoption of such records. More organizations adopting EHRs will facilitate broader dissemination of implementation best practices, with the hope of further shortening the time required to take advantage of advanced EHR features.